Good afternoon. I'm Dr. Val Johnson, and we have Dr. Petronella Adomako with us also, and we'll introduce Dr. Eric Lindley, who will be the speaker this afternoon. Dr. Lindley was born and raised in North Ogden, Utah. He completed a Bachelor of Science in Exercise Physiology before going to the George Washington University for medical school. He then returned to Utah and completed house staff training at the University of Utah. He is an interventional cardiologist and holds 5 active board certifications in interventional cardiology, general cardiology, echocardiology, nuclear cardiac imaging, and internal medicine. Currently, he is the Associate Medical Director of Cardiovascular Medicine for the North Market of Intermountain Healthcare. He is also the Chief of Cardiology at McKay Hospital, the Director of Structural Cardiac Interventions at McKay, and holds an academic appointment as an Adjunct Associate Professor at the University of Utah. Dr. Lindley will talk to us about what he chooses in the area of cardiology, and after he's spoken regarding that, we may have some questions to ask of him. We'd like to welcome Dr. Eric Lindley.
Thanks. Appreciate it.
I'm actually curious, what made you go into cardiology?
Great question. So it was sort of on, I don't know if it was shortlist or not when I went to medical school. My mom was a nurse at McKay actually for like 40 something years. She worked in the cardiac ICU. She was the very first charge nurse the day that the CCU opened at McKay simultaneously at LD. So I had a little bit of exposure as a kid growing up, but then as I was kind of in junior high and high school, she transitioned out of the ICU and was working in pre and post-op. So I went to medical school after college. And during college, I worked actually at Primary Children's Hospital. I was a CNA on the cancer floor, actually at primaries. So I didn't know what I wanted to do exactly. I like sports medicine. I thought about maybe doing ortho, even peds ortho. Then I got into medical school, and my wife, we got married right before I went to medical school. My wife got a job just randomly as a medical assistant for a group of interventional cardiologists they were in Virginia. They're just outside of DC. And so they suddenly became kind of my instant mentors, and they really took me under their wing and were just a great group of interventionalists, 2 of them in particular, John O'Brien and Dr. Rogan. And they were at Inova Fairfax. And like I said, they were kind of my mentors. So I knew basically by the time I finished my first year of medical school that I wanted to be an interventional cardiologist. So that's my story of how I kind of got from point A to point B.
And what's new in different areas of cardiology? That's a broad topic, seems like.
It is. And I think in cardiology, you really have to kind of break it down into the subspecialties. Now, I think there's something like 8 or 9 recognized subspecialties in cardiology now, and 5 or 6 even subspecialty boards within cardiology beyond just general cardiology. So I would say, I think the best way to really approach that is really kind of to look at it per area. In the world of heart failure, the most exciting things that have come out of that, how it pertains, I think, to primary care and specialty medicine, is really the new diabetes drugs, all of the new SLTP2 and all the other acronyms that come with all of the new diabetes medicines that I didn't graduate from medicine that long ago. And they weren't around at all, even, 5-6 years ago. And all of those actually pertain now to heart failure patients and really markedly reducing morbidity, mortality, hospitalizations. There was just a trial released again with one of those agents in patients without diabetes with systolic heart failure, reducing the risk of morbidity and mortality. And so there certainly is an access there from a biochemical standpoint between the relationship of heart failure and insulin resistance and whatnot. And so I think that that's kind of the newest thing in the world of heart failure is, both of our heart failure experts, for instance, at McKay, have been prescribing diabetes drugs for the, I think, kind of first time. So in other areas like electrophysiology, in the last really 18 months, year to 18 months, the biggest trials that have really come out have shown the efficacy of early AFib ablation therapy being superior to drug therapy. So as that technology has sort of advanced in the last 20 or 25 years, Really all the algorithms have always been patient with AFib gets put on drugs first, and only when they break through drugs should you be, pursuing AFib ablation. But we've just frankly gotten better at it. Most recent trials show that patients with good protoplasm, early onset paroxysmal atrial fibrillation are really benefiting from early ablative therapy compared to drug therapy or antiarrhythmics. The likelihood of them staying in sinus rhythm over the long run is superior when it comes to ablative therapy. And it just takes a while to get there when it comes to a procedure, right? Because all of a sudden, Medicare's got to pay for it, right? As soon as a society says it's the preferred therapy, insurances have to pay for it, and they're not cheap. But if it keeps patient out of the hospital, prevents strokes, and improves quality of life, then it's good. I'm glad that we do the trials. So I would say that's the biggest thing in the world of atrial fibrillation. What I would say, I'm biased to it as a structural interventionalist, but structural intervention has exploded in the last 10 years. The way we treat valvular heart disease has changed so dramatically in the last 10 or 15 years that it's revolutionized cardiology. The preferred method of treatment for a vast majority of patients with aortic stenosis now is TAVR, or transcatheter aortic valve replacement, a less invasive way of providing care for AS patients. Just last week in our major publication, JACC, they published the 2-year data from the low risk trial of TAVR that still continues to show superiority over surgery when it comes to their primary endpoints. And so I think that TAVR is just sort of the tip of the iceberg now that we've done in the last 10 years. And there's been multiple trials in the last couple of years looking at less invasive interventions for the mitral valve. Just in January, there was another big trial published on less invasive interventions of the tricuspid valve. So the ability to treat valvular heart disease and other structural heart disease has really just advanced so much in the last 10 years. And luckily we have multiple centers within Intermountain and outside of Intermountain here in the state and the neighboring states that allows us to really look at a patient with kind of a multidisciplinary team and decide really what are the options, and to present those options for patients and decide what's best, because it doesn't mean a catheter-based solution is always the best. There's no substitute for high quality cardiac surgery. I learned that from one of my mentors at the university. Dr. Fang always said that, and I always took that to heart, and it's true. So I think that just the amount of options that we have for patients nowadays is pretty awesome. And to that point of multidisciplinary teams, I think that is really, in terms of what's new in cardiology, I think that is really the wave of the future. I think that I'll call it old school thinking of, I'm a cardiologist, this is my patient, I'm going to be the one that dictates what kind of care and referrals that patient receives, and it's all going to go through me. I think that is an old thought process that needs to be put to bed. I mean, we need to stop thinking in those terms and really need to start thinking about how teams of people can take care of patients, because I have one specific skill set, and that one specific skill set can't necessarily provide all the options that are available to a patient. And as soon as we kind of have that attitude that I'm the only one that can provide that care for that patient, I think we're really selling ourselves short, especially in the world of cardiology. So I think really team-based care and the way we take care of patients on those teams is really kind of the future. I think in a lot of areas of medicine, but certainly within cardiology, I think it's the only way to take care of people moving forward.
That's a lot to learn. So,
Yeah.
you said early AFib. What is considered early AFib?
Let's say you have a 60-year-old who is otherwise fairly healthy. They have high blood pressure and sleep apnea, and they come into the ER in atrial fibrillation, and they give them an IV dose of diltiazem, and they quickly convert into sinus rhythm. I'll throw that patient out there. Those are the kind of patients that these new trials have really looked at, of saying, do we want to put a 60-year-old like that on antiarrhythmic medication that do have side effects, just like any other medicine, but certainly antiarrhythmics have them? And do we want to sometimes spend months on maintaining sinus rhythm to see if a patient is going to feel better or not? Is that the right approach to take? Or do we move very quickly into saying, yeah, this patient was sick when they were in AFib. They felt terrible to the point where they came to the ER. We know they have symptoms from their AFib. Why don't we move toward a more definitive therapy like AFib ablation? AFib ablation is not a cure. Any cardiologist that tells you AFib ablation is a cure is selling you something, and it's not true. It's just a therapy, just like a drug is. It just turns out that it's a pretty effective therapy. And in these trials, these new AFib trials, they're not just doing an EKG and follow up and saying, oh, you're in sinus or you're in AFib. They're actually implanting implantable loop recorders in all these patients. They have, full-time feedback on these patients of whether or not they're having reoccurrences of their atrial fibrillation. So they're really well-performed studies. And I think that the efficacy of something like that is important when it comes to proving that a procedure, an invasive procedure, is better for a patient than a pill. It takes a lot of money to run those studies, and it takes a lot of support. And like I said, some of the newer studies have been really promising.
The heart failure, you said diabetes drugs, are they the same dose as the diabetes drugs? Is it all class? Just is that particular group of diabetic drugs that are being used?
Yeah, it's just that newer class. The newer class, not only is it biochemically beneficial, but some of them actually act as a mild diuretic as well. They have a diuretic property, which is also probably one of the benefits that the heart failure patients are getting from it. It is the same dose typically as you would prescribe in a diabetic patient. The good thing about those new drugs is they're obviously less likely to cause hypoglycemia like some other medications. And so that's why you can prescribe them even in non-diabetics. It's probably some degree of the biochemical changes that occur with them, as well as some mild diuretic effect. There's also most of those drugs, not all of them, but most of them actually produce some degree of weight loss. In heart failure patients, we know, 5 to 10 pounds of weight loss beyond just a diuretic effect actually shows benefit in those patients. So I don't think it's surprising, but like I said, it's a little interesting having to study back up on diabetes drugs that I thought I left behind for the most part a few years ago, but certainly they've come back around.
That you mentioned the low risk trial for the TAVR. What is that?
There's a large group of trials called the partner trials. The very first partner trial was published back in 2009 with TAVR. And the very first one that was published was patients who were inoperable. So they were such high risk that the surgeon was saying, no, thank you. The very first one was comparing medical therapy only for severe aortic stenosis inoperable patients compared to TAVR. And it showed a large benefit for TAVR. And then the next iteration of partner trial was high-risk surgical patients versus TAVR that got randomized in a one-to-one fashion between surgery and TAVR. And again, TAVR proved to be better in that scenario. And then a couple of years ago in 2017, I want to say, don't quote me on that, but a couple of years ago, then the intermediate risk patients then got trialed in the same fashion in what was called Partner 2. And then Partner 3, which came out a year ago, went all the way down to basically all comers or a low risk trial in TAVR. And so we got the 1-year data a year ago showing the superiority of TAVR compared to surgery. And then just in the last couple of weeks, we now have the 2-year data. And all the partner trials kind of have 1, 2, and 5-year planned follow-up. So this is the kind of planned iteration of what that looks like. At that, Partner 3 was 1,000 patients, randomized 1-to-1 surgery versus TAVR with good hard clinical endpoints, meaning death, heart failure, MI, strokes, things like that showed the superiority of TAVR over surgery.
Interesting. What about the mitral valve? So are you replacing mitral valves as well in that manner?
To some degree, the mitral valve is, from an anatomic standpoint, is just a different bird altogether. The way the mitral annulus, the way the mitral valve, the way the submitral apparatus, so the papillary muscles, the chordae, the way that all interacts with the ventricle is all different than the way the aortic valve works. The aortic valve is sort of putting a round peg in a round hole, and it works pretty well. Again, the mitral annulus and apparatus is a whole different ball of wax. So there's a few FDA approved indications right now for transcatheter aortic or mitral valve replacements. So the way it stands right now is if you already have a bioprosthetic mitral valve in that was placed, say, surgically 10 years ago that is now dysfunctional, either stenotic or regurgitant, then right now there's an FDA approved indication to do a transcatheter mitral, what's called a mitral valve in valve procedure. So you go venous access, femoral venous access, do a transeptal puncture, and then go in antegrade from the left atrium into the left ventricle with your equipment and place a valve inside of that framework that already exists from the surgical valve. It sort of needs that framework to hold on to. That exists anatomically in the aortic position, less so in the mitral position. So that's one of the indications from a percutaneous valve replacement. But we've extended that now even beyond that to if someone, let's say, has a mitral ring in place from a previous mitral repair where they have their own native valve tissue and have a ring that was placed around that mitral valve. We're using that ring as a backbone to place a valve experimentally. Also in patients who have a lot of mitral annular calcification. So the older we get, we build up a bunch of calcium around our mitral annulus. And sometimes we're using that as a backbone to place this mitral valve in, again, more experimentally now, not necessarily indicated, but certainly will be over the next few years for these higher risk patients. And then ultimately, probably the most landmark trial, at least in the last 2 to 3 years in cardiology, other than the TAVR-LORIS trial, was a trial called the COAPT trial. So COAPT was using a device called a MitraClip. So MitraClip sort of, it kind of looks like a little barrette or a chip clip, frankly, that you'd put on a bag of chips, but smaller and sterile, that you go in through a same venous approach, transeptal puncture from the right side of the heart to the left side of the heart. And you clip the leaflet tips of the mitral valve together to create a double orifice mitral valve. So you reduce the amount of regurgitation that's occurring, not to zero, but you reduce it. It's based on an old surgical technique called an Alfieri stitch that didn't really work all that well, but percutaneously, it works pretty well. In the COAPT trial, if you talk to the trialists, of which Intermountain Medical Center was one of the trial sites, it was one of the hardest trials to enroll. The patients had to have heart failure and low EF and severe mitral regurgitation. And then they actually had to have a standard of care of heart failure therapy. And it turns out that when you're really aggressive and you use a standard of care for heart failure therapy, people tend to get better. And so they get put on heart failure meds. And if they got better, they kind of dropped out of the trial. And if they didn't, then they got enrolled they basically got randomized to either clip or ongoing medical therapy. And the patients who got clipped did markedly better. Their morbidity and mortality was pretty tremendously favored the MitraClip. And so based on that, in a high risk patient that got low EF and bad MR, sort of the therapy of choice now. And in that space, in the mitral space now, the technology's exploded. There's, I think, 5 or 6 or 7 different companies that are working on percutaneous valvular options to replace the whole valve apparatus with docking stations, with transapical approaches, transeptal approaches. You name it, there's a company inventing in the mitral space. It's quite exciting. And if you're really into bioengineering, it's a cool thing to look up for sure. But there's a lot coming down the pipeline. I think in the next 5 years, where the mitral space will be similar to what TAVR was 5 or 10 years ago, in what our ability is from a less invasive approach to the mitral valve, especially in high risk patients. And then kind of the last valve in that group is the tricuspid valve, which we're just barely at the very tip of the iceberg of what we're doing. And it's basically using those same type of clips that I just mentioned for the mitral valve and using it on the tricuspid valve. The right heart is a whole other ball of wax, though, that we're still, I think, again, just scratching the surface in whether we can affect it or not. But like I said, the mitral space is where probably structural heart has expanded the most in the last 5 years. A lot of exciting technology.
Yeah, that's really interesting. What about coronary artery disease? Any advances there, or it's just the same old cabbage?
Yeah, a little bit of the same old. We a couple of years ago there was a bioabsorbable stent that was actually originally FDA approved after a couple of trials called the Absorb trials, and the scaffold of the actual stent was truly bioabsorbable. After about a year, it was gone. And the premise behind that is when we put in our modern day drug-eluting stents, is even though your body grows skin over those stents, or what we call epithelialization of that, it doesn't behave normally. Your epithelium, your blood vessels And the cells that are on the luminal side of that are actually very biochemically active, releasing nitric oxide and other chemicals that allow that blood vessel to dilate and to constrict. And when you put a stent in it and just turn it into scar tissue, it doesn't behave normally. So the thought behind that is, if I put in a bioabsorbable stent, I relieve the acute blood flow issue, and then over time allow that scaffold to go away and allow the artery to heal on its own. Can I restore some of that function? So that was sort of the premise behind bioabsorbable stents. So the absorb trials were positive, and the stent actually got approved, and it was starting to get put in a few patients, and it only lasted about a year before actually it got withdrawn from the market. What they found was some late complications as they were releasing it more. People were getting actually thrombosis or clot in the arteries where the bioabsorbable scaffold was. So it's a little bit back to square one with the bioabsorbable stents. I imagine in my career at some point we'll be putting them back in. But our kind of third and now fourth generation drug-eluting stents that originally were released in 2002, and like I said, now we're on, next year will be the 20th anniversary of drug-coated stents, and on the third or fourth generation of them, they're so darn good that it is really hard to compete with them. The amount of restenosis or re-narrowing of the stent still remain less than 5%. The likelihood of thrombosing or developing a clot inside an appropriately placed stent is incredibly low, kind of in the 1% and 2% range. So they're just really good. So to find something better, you're talking about 20 and 25,000 patient trials to compare head to head to be able to power a study appropriately. And so that's a hard thing to do, to show a significant difference. So from a stent standpoint, I would say that we're in a very similar place to where we have been in the last 5 and 10 years, which is actually a really good place. In terms of coronary disease, or I just say vascular disease in general, we've got kind of a new kid on the block when it comes to lipid management. So statins have been the backbone of lipid management for decades, the tried, true, tested, most researched medicines on planet Earth. We love them. We love statins. Yeah, they probably should be in the water. Unfortunately, they get an inappropriate bad rap, but that's okay. We can answer Dr. Google when patients bring questions in about statins. But there are truly probably somewhere between 1% and 5% of patients that are truly statin intolerant. The newest group of medications that's now been out for a few years, 4 or 5 years now, are a group of medicines called PCSK9 inhibitors. That's the class of medicine. Rather than a pill, it's an injectable that you take once or twice a month that dramatically reduces LDL cholesterol independent from the pathways in which a statin works, with really marked improvement in things like cardiovascular death, stroke, things that really matter. The problem with the PCSK9 inhibitors is not a side effect profile. They're actually incredibly well tolerated, more well tolerated than even statins, which are well tolerated. The problem is cost. They're wickedly expensive. There's 2 on the market right now, with a third hopefully entering the market in the next year or 2. The third one we're excited about, the third drug in that arena is going to be a once every 6 months or once a year injection. So kind of imagine going to your cardiologist and getting your shot in your backside and you're good to go from a cholesterol management standpoint. So that may be in our future. But like I said, that third drug will hit the market hopefully here in the next year or 2 to compete with the other 2. But it is good to have an alternative to statin therapies for kind of that, like I said, that 5% of patients, or the patient who's on a max statin dose and continues to have heart attacks, continues to have strokes, continues to develop peripheral vascular disease. All of the original trials in PCSK9 inhibitors were built on the backbone of statins. So you can add it into statin therapy to drop the LDL cholesterol as low as humanly possible. We really haven't found statistically an LDL that's too low yet. So lower the better. And even though the American guidelines will say if you've got vascular disease, you want your LDL cholesterol, lower than 70. The European guidelines recently have dropped that all the way down to 50 or 60 if you've got other complicating factors like you have recurrent illness and recurrent vascular disease. But again, most of us and all of the data would suggest, if you could really drive LDL even lower, 20, 30, 40, the likelihood of being able to form plaque just goes way down. So from like I said, general cardiology coronary standpoint, the PCSK9 inhibitors have starting to catch a little bit of wind here in the last couple of years.
So for now, they are not first line, right?
They're not. It's still statin therapy. And I tell that to patients. It's still, the data with statins, we have hundreds and hundreds of thousands of patient years in statin trials. They work. They reduce the risk of heart attack and stroke. They make you live longer, both in primary and secondary prevention, especially in secondary prevention. So it is still definitely the first line therapy. I don't even bring up the injectables unless truly a patient starts becoming intolerant of the statin therapy, or in the patient that is on max dose tolerated statin therapy, their LDL is still 100. They had a big MI, I'm putting in more stents 3 years later. Those are the patients that I add the injectables as adjuvant therapy.
Well, cardiology is interesting, huh?
Yeah. We certainly have always, I don't know, the good thing about it is we've got a trial for everything. And that's also the bad thing, right? I think that we used to do that as fellows, is you could have an argument and argue basically both sides of almost any clinical decision. And each person in the argument had 2 or 3 trials with 20,000 patients in it. You compare it to, say, a cancer trial that has, 60 in each arm to get medication approved. And so as ubiquitous as cardiovascular disease is, obviously we have a big patient pool to draw from. But again, it's both our blessing and our curse, certainly in CV.
So what should the non-cardiologist provide about how to help their patients?
I think number one, that we have really great guidelines out there to help guide the primary care provider of assessing a patient's risk. Because a 20-year-old with a LDL cholesterol of 120 and an 80-year-old with an LDL cholesterol of 120 are 2 very different patients. And that's really based on risk. The risk an 80-year-old has of dying of an MI or a stroke with an LDL cholesterol of 120 is markedly higher, all other things considered equal, than a 20-year-old with that. And so we've got great guidelines out there that really guide how we should treat, what I'll say, is primary prevention in cardiovascular disease. So get your patients exercising, get them on statins when it's appropriate, get them to stop smoking, get them to lose weight, et cetera. I think is all really important. The next step I would say in that is, as we just talked about, especially in the world of structural interventions, there are so much we can do for patients to help them feel better. Too often I get a patient in my office who has been sick for sometimes a couple of years with heart failure symptoms that they themselves either told their primary care doctor, "Oh, I'm just too old," or the primary care doctor said, "Well, of course you are getting run down. You're 82 years old. You should get run down." But it's really their severe mitral regurgitation or their severe aortic stenosis that is really making them feel that way. And we've got so many therapy options to offer those patients. We just need to get them into our office to be able to offer them that. So before you kind of, I would say, put the patient out to pasture and say, we shouldn't be more aggressive in this patient, send them to us, see if there's actually an option. And there might not be. I would say about 5 or 6 new TAVR consults a week in clinic, and about 1 out of those 5, we recommend hospice care because there isn't much we can offer. But at least we answer that question, both for the patient and their family and the primary care provider, is that we've extinguished the options that certainly could or could not exist. The average age of TAVR patients was 84. It's dropped down a little bit now. It's 81, 82. I've put valves in 95-year-olds before that did great, stayed less than 24 hours in the hospital and went home with a new heart valve. So age is truly simply a number when it comes to things in the world of cardiology. If I could get that message out to the primary care providers, it would be that. The other thing I think right now that's tricky in the world of primary care providers and getting those patients to us in cardiology is what COVID has changed for us in going virtual for so many visits. I think that telemedicine and virtual visits certainly is a huge part of the future of medicine. And especially for the younger patient population with acute issues, I think telemedicine is absolutely what we should be doing. But sometimes when we've noticed you are doing a televisit with, again, an 82-year-old who's sitting on their couch and you say, "Hey, how are you doing?" And they say, "Oh, I'm getting along just fine." And then they kind of change the subject and they go on, and you're not listening to them with a stethoscope. You're not ordering echoes. You're not hearing their spouse when they're sitting in your office say, that's not true. They're not doing fine. They stopped mowing the lawn. They stopped going out and get the mail. They stopped going to the grocery store with me. And that's the most common finding we see as patients develop valvular heart disease in their 80s. Is it's not that they don't come to your office and say, I had chest pain and passed out yesterday. That's an old dogma, for instance, when it comes to aortic stenosis. What they come to your office and tell you is, I don't grocery shop anymore. I hired the kid next door to mow my lawn this year. I didn't go to my grandkids' graduation because I knew I'd have to walk up 2 flights of stairs, and I don't feel very well when I do that. And sometimes it's hard to tease that out in some of our older patients over a televisit. We've all seen volumes go down in the world of structural heart kind of over the last year. And we're a little concerned about what televisits are going to do. So we're excited as anyone else about the vaccine to be able to, I think, get a few more patients physically in clinic, especially our older patients. Again, the younger patients, I love doing tele appointments. It's awesome. But some of the older patients, I think there's value in seeing them in person.
I've been enjoying the talk so much, I completely forgot about COVID. So since you brought that up, what effects have you seen with COVID on the heart?
Kurt Knowlton, who is sort of my compatriot at Intermountain Medical Center and a myocarditis expert, he did a really nice webcast the other day on a Facebook Live for us on Intermountain. So if anyone wants to check that out, please do, because he's really become one of our resident experts on that. But we know that COVID-19 absolutely affects the heart. I've seen several patients with pretty severe myocarditis from it. We know that a patient who has underlying cardiovascular disease who develops COVID has a markedly higher risk of morbidity and mortality. Patients who presented critically ill with COVID, especially during our peaks, who also had positive cardiac biomarkers, so their troponins were positive, that it risk stratified them into the very highest risk category of mortality. So as soon as the heart was involved, plus COVID, plus a ventilator, almost always equaled death, frankly, which was scary, obviously, as we didn't know exactly where the pandemic was headed. And so we know that COVID can do that. The other thing that I've seen on a couple of patients is kind of late presenting MIs. They get sick with COVID, they test positive, let's say they've got cough and loss of taste. They're getting better for 10 or 15 days, and then all of a sudden they get worsening shortness of breath. And a lot of times those patients have just thought, oh, it's just my COVID. And then they present to the hospital having an MI. As we know, COVID is a prothrombotic state. So we've seen even young patients develop thrombus in normal coronary arteries. We've had multiple 20-year-olds who have had MIs with thrombus in their coronaries from COVID. We've also seen then older patients who have atherosclerotic coronary disease develop true STEMIs with plaque rupture in the setting of high inflammatory response from COVID. Then on the flip side of that, back in the spring when everything really shut down, including almost, some of our, all of our, or a lot of our medical care, except for emergent care, as we were, deciding on how to deal with all of this in March and April, there was a lot of large studies published with the title of Where Have All the STEMIs Gone? Right? ST elevation MIs should not have decreased during COVID, right? If anything, they should have increased. And during those months, we saw a decrease in acute MIs, which really meant that people were sitting at home having their heart attacks and not coming in. And unfortunately, we saw some really late presenting MIs. In the last 2 months, I've had 2 patients die as late presenting MIs, both patients saying frankly, we were scared to come into the hospital. We didn't know if the hospital was full. We didn't know if it was the right thing to do. We didn't want to catch COVID by coming in, despite all of our kind of public service announcements that it's a safe place to be, that we're ready to take care of you, that we've got capacity to take care of you. You have one neighbor tell the other neighbor, oh, I think the hospitals are full. They develop chest pain one night. They don't come in until they develop heart failure symptoms 5 or 6 days later. And like I said, I've had, unfortunately, 2 patients pass away in the last couple of months from complications of late MIs that we haven't seen in decades since we've been able to provide urgent revascularization strategies to patients. So unfortunately, COVID has hit home with us just as badly as it has in a lot of other areas. And like I said, we've encouraged all of our patients that have cardiovascular disease to get vaccinated. A vast majority of them have gotten vaccinated and or are excited to get vaccinated when it's appropriate. And now with it being, as of a couple of days ago, any patient with cardiovascular disease is now appropriate for vaccination. So we're certainly encouraging it.
I was going to come to this last question of yours regarding COVID, but I think that's been well taken care of. I want to backtrack just a little bit back to the arrhythmias. And in regard to ablations, what techniques, what procedures are available currently for ablation?
There's really two main ones. And, if you talk to an electrophysiologist, they could kind of go, I would say, kind of on and on into the different techniques and whatnot there. But I would say the two main areas are RF ablation, which is sort of point and shoot, I'll call it. And then the newest technique that a lot of our electrophysiologists are using is something called a cryo balloon, which is actually a small balloon that goes into the pulmonary vein and freezes, causes a chemical burn via cold rather than heat, but it's the same process, right? The balloon goes into the pulmonary vein and creates a circumferential freeze or chemical injury to ablate atrial fibrillation. That's most AFib. It is really from the origin of your pulmonary veins as they enter the left atrium. So when we say AFib ablation, there's actually multiple techniques, but the first one is really what's called a pulmonary vein isolation. In other words, creating an electrical scar around the pulmonary veins to keep the AFib in and allow the sinus rhythm of the heart to then kind of wash over the atria. As people sometimes need repeat ablations in the left atrium, it's to, clean up spots that maybe were missed previous or that have broken through. But those are the two main techniques that I would say are used today, either RF ablative therapies or cryoablative therapies. I can tell you that electrophysiologists are usually in one of two camps, and they really believe in the camp that they're in and throw sticks and stones at the other camps a little bit. So it depends on which paper you read and which electrophysiologist you talk to about which technique is better. But those are the two main ones that you'll hear, RF and cryo.
And these are both interventional.
Mm-hmm.
Are there any ideas about being able to use external means of ablation?
The external techniques are really surgical techniques still. So the maze or mini maze procedures that have been around for a lot of years is really a surgical technique in which a surgeon is, let's say, doing a mitral repair replacement on a patient with longstanding atrial fibrillation. They'll actually create external scar lines on the outside of the heart by cutting and suturing and disrupting the abnormal electricity of the heart. And there's a few different techniques to do that. There's now a couple of different hybrid procedures in which a surgeon, either thoracoscopically or through a sternotomy, but can do it less invasively thoracoscopically, will create external burn lines. And an electrophysiologist will then create internal or endocardial burns to try to control the atrial fibrillation. So those are really nuanced techniques that are newer and small trials showing their efficacy comparatively. But typically an external burn line is going to be surgical, even though now we do have some of these newer hybrid approaches that are coming down the pipeline.
But not a Star Trek, put your cell phone on the person's chest and push an app button.
Yeah, not yet. But, there's a couple of things I can tell you that we've started implanting at McKay that's been around a few years, but we've started implanting it in Intermountain facilities, a device called a CardioMEM device, which is a small, basically resistor that you put in a pulmonary artery through just doing a right heart catheterization. And it talks to the patient's pillow. They basically have a transmitter on their pillow at night when they lay down, and it gives us right heart cath data. So it tells us what their wedge pressure is. It tells us, we use it to say, hey, before a patient calls us in the heart failure clinic to say, hey, I'm in trouble, I'm up 5 pounds and I can't breathe. We call them and say, hey, your wedge pressure went up 5 millimeters of mercury in the last 2 days when you've been sleeping. Let's increase your Lasix. So there's some of that Star Trek-y stuff that's starting to get out there from an interventional technique that still requires some invasiveness to it, however.
Do you have any other new predictions for the future or thoughts about, I wish this would happen?
Oh, great question. Yeah, well, there's a lot of things I wish I would have invented. Yes. But Aside from that, I do think that a couple of things need to happen in the world of cardiovascular medicine. And just like any other area of medicine, we need to do much better when it comes to diversity and equality. If you are a upper class individual in a large city, the cardiovascular care you receive is different, frankly, from a minority that lives in an underserved area. And we need to get better at those health disparities, just like we do across medicine in general. But cardiovascular disease is certainly one of those techniques. We need to learn how to get some of these newer techniques to countries that don't have as many resources as us to be able to treat them. Because just like in America, now every country on planet Earth, cardiovascular disease is the number one killer. And so we need to learn how to do that better in terms of getting it into communities that are underserved communities. So I think that's number one, that we really need to do better, make better strides, concerted efforts on how to do that. I think Intermountain Healthcare does a nice job of that. I think the University of Utah does a nice job of that in terms of providing quality charitable care. But I think it needs to go beyond just charitable care in terms of getting into diverse communities. So that's one area. I do think that what we're doing in the world of structural heart disease will revolutionize whether or not someone needs their chest opened or not over the next 10 years. No one wants to have their chest open. Sometimes it's the right thing to do, but no one wants to have it done. And I think as we get better and better at these techniques, that our likelihood of needing to do that will get better and better. And then I do think these new injectable PCSK9 inhibitors will make a difference. I think that we'll see a reduction in MIs over the next 10 to 20 years by really driving down people's LDL cholesterol. So I think that's good. And that's where I would predict that going. And then in my career as interventionalist, I'm sure that 20 years from now, I'll be telling some young fellow about the stents I used to put in, and they'll laugh at me like I'm a dinosaur at that point. And I hope that happens, honestly. I love that. That's why I love about cardiovascular medicine and being on the cutting edge of it and how rapidly it's changing. I hope I get laughed at and get to tell old stories about how big of catheters I used, even though they're tiny, and how the stent techniques that I used, even though, like I said, I wouldn't mind getting laughed out of the room when teaching fellows someday. So that's where I hope it goes.
What should I be doing about my heart health? As one of the questions we have put out there. What should I be doing as a layperson to improve the health of my heart?
I think being aware simply that, hey, if I am 35 or 40 years old, alive and otherwise healthy, living in America, what's going to kill me is my heart. You could say that statistically, right? If you're younger than that, then it's still accidents and firearms and things like that, or the pool that you fall into when you're a kid. But once you hit about age 35 or 40, that switch flips and it's cardiovascular disease. So I think recognizing that early on, making sure that you're seeing your doctor, getting your cholesterol checked. If you smoke, knock it off. E-cigarettes and vaping are probably just as bad for the heart and lungs as real cigarettes. We consider them equivalent in our worlds. Stop smoking, start exercising, be of healthy, normal weight. Decrease the red meat and pork intake that you're eating. If you're choosing a diet out there, the Mediterranean diet is what you should be choosing. It's the one diet that has true proven benefit to reduce your risk of heart attacks and strokes. And when someone says, well, gosh, I don't want to go on a diet, I hate the term diet as well. But if you compare a Mediterranean diet to an American diet, the differences in those two diets are what we call the meats and sweets. It's no more than 2 servings of red meat or pork per week or less. And eating 3 pieces of cheesecake after dinner is a very American thing to do. I actually do this for my patients every year. I look up the top 10 restaurants in Sicily as being in the Mediterranean. Typically, only half of them, every year it's a little different, but anywhere from 3 to 7 of those restaurants don't have a dessert menu. Can you imagine going into any restaurant, let alone a 5-star restaurant in America, and not having a dessert menu? No, that doesn't exist, right? But in areas in which people live the longest, like in certain islands in Japan, Okinawa, etc., and then the ring around the Mediterranean is where the humans live the longest. And they don't eat red meat and pork, or very rarely. They don't eat sweets. Do they eat everything else? Yes. Do they eat cheese and pasta and grains? Absolutely. If you're of normal weight and you're a non-diabetic, those things are not evil. Fats have never created cardiovascular, other than trans fats. We'll take that off the table. But other than that, fats have never created cardiovascular disease. That lie has been, disproven by the cardiovascular world for decades. So I'll have patients all the time come in and say, oh, well, if I just didn't eat that greasy hamburger, it's not the grease in the hamburger that I'm concerned about, it's the meat. And so if we can get patients to eat less red meat and pork, I think we're going to make a dent in cardiovascular disease. So if you yourself are sitting there tonight thinking, I don't want to die of a heart attack or stroke, what could I do today? Check the scale, get to a normal weight, decrease the red meat and pork in your diet, start getting some physical activity, lay off the cigarettes, lay off the e-cigarettes, and then make sure you're seeing your doctor at least once a year so they can make sure. There's a lot of things we can do in the world of primary prevention to make sure that we're staying on top of it.
I feel like you're talking to me, man. It's so difficult.
I know, it's terrible. I hear you. It is. It's awful, and it's hard. And I try. It's important. I think during COVID, I've taught patients also to just give yourself a little break. It's been a hard year for all of us, and to not beat yourself up too much about what the last year has been. But there's definitely a light at the end of this tunnel with our vaccine and with our still distancing and with our masking. All of that works. We've proven that, and science has won the day. That's the great thing about this last year. And I tell my kids that all the time, like, science is awesome, and science is the reason that we are out of this. That is the only reason. And I love that about it.
I've really enjoyed this and appreciated your speaking to us, Dr. Lindley, and the questions from Dr. Adomako. As a person who has experienced some of these things, like having his chest opened, I don't look forward to having that done again. I hope that something will come along. If I need to have that done, there will be a Star Trek alternative or something.
Once is enough. Once is enough. I always tell people it's okay to get your chest cut open once, but never twice. I always keep the surgeons out of business that way.
Okay, and I would agree with that.
Oh, one last question. So if we need to get patients to you, how do we get in touch with you?
Best phone number to get us is 801-387-3400. That's the cardiology clinic at McKay. Or your primary care doc or any other doc can just refer to McKay Cardiology. We're happy to see you. Our doors are open. Every single one of our providers is accepting new patients every single day. So no one's practice is closed or anything like that. So give us a call and we're happy to see you, and we'll see you pretty rapidly. We've got a big team of providers of 13 docs and just as many APPs that are ready, willing, and able to help you. So that's the best way to get us.
I have appreciated being able to participate in this with you, Dr. Lindley and Dr. Adomako. I don't know what to say beyond that, other than this has been very nice, and thank you again.
So thank you once again, Dr. Lindley, for taking time out of your day to talk to us. It's been a very informative lecture. We really do appreciate that. I've learned a whole lot. Well, I have a lot more to learn, but thank you once again.
Thanks for having me, guys. Appreciate it.
The producers for this podcast are Clark Madsen, MD, MS, Teresa Pasquedra, MPC, and the Ogden Surgical-Medical Society Board of Directors. The executive director is Teresa Pasquedra, MPC. Your hosts for this episode were Val Johnson, MD, and Petronella Adomako, MD. Editing and sound design is by Colton Gomez, and this is all supported by members of the Ogden Surgical-Medical Society.